Hi, this is Dr. Gabriel Chu, and this is one of my cataract videos on a 5 plus white cataract where I'm going to use Vision Blue and put in a toric lens. So I always like to make the para first, which I made and grabbed onto with my 0.12. And that gives me counter traction for doing a single planar in and out keratome incision, which in this case is a 2.5 millimeter. I'm injecting the 1% lidocaine that has a lower pH slowly in at least 1 or 2 injections, just to reduce discomfort for the patient. This is Vision Blue used to stain the anterior capsule because I can't see it, or it's difficult to get a red reflex. Then I'm using BSS to flush it out, so then I can have good visualization. You'll notice my draping. Again, I try to drape the meibomian gland so I don't get too much sebum in the tear film, which creates reflections and difficulty seeing. Reinflate the anterior chamber with viscoelastic. You can see that the eye is quite mobile, and all we need is a saccade here to make a rhexis run. So I always try to use my 0.12 to make sure I have a good grasp on the eye. There's been countless times where I don't hold on to the eye and a saccade or some movement causes the rhexis to run, and then now I'm wondering whether I need to do a vitrectomy. So cystotome is used to create a nice flap, and I flap it upwards, ready for grasping with my Utrata. I always try to reposition every time I regrasp. I try to reposition the flap so it's easy for me to grab. Because it's a tumescent cataract, I try to regrasp several times so I have better control over the leading edge of the capsular rhexis. Once you have a complete capsular rhexis, I hydrodissect right in the space between the anterior capsule and the cortex. And I usually just do a double wave. So I go on one side and then the other side to make another wave. Sometimes you can see, most of the time you can see the wave, but sometimes you can't see the wave very well. So you have to trust that there's a good dissection. I don't typically rotate because I'm confident that I got a good dissection. I remove the superficial layer of cortex so I can have access to the epinucleus and nuclear layer. I like to do a primary horizontal trop, so I bury my tip and I do a horizontal trop across, so I have 2 opposing forces to reduce stress on the zonules. I do bury my the tip of my chopper, so I get a good chop. Okay, once I have a good chop, I take the pieces quadrant by quadrant. When I do rotate, you'll see I always try to do a bimanual rotation to reduce stress on the zonules. If you have a unilateral force, it could cause a zonular breakage and dehiscence. And as you can see here, the rest of the nucleus and epinucleus comes quite easily, and there's very little cortex left. When I come out, I try to come out on foot position 0. This helps because it reduces the pressure drop when I release, when I come out of the eye. So if I can reduce the pressure while I'm still in the eye and leave it at foot position 0, then that helps with the patient discomfort. It also helps if you have a floppy iris where the iris tries to flop out. You'll see here that there's very little cortex, and I'm trying to remove as much as possible. There is still a PSC component to the cataract. So I'm going to come in with a 27 gauge cannula, and just parallel to the posterior capsule, I'm irrigating with just BSS solution, and that by itself will remove most of the PSC component. If there's any PSC component remaining, which you can see there's a slight little bit remaining, I usually deal with it in a non-aggressive manner, i.e. I leave it there and I will YAG it, YAG laser it later. I've already pre-marked the eye while the patient was sitting up, and now I'm putting the final marking, a 2-step marking procedure. And to provide counter traction, I use 0.12, and I use a wound assist injection technique. And I don't use a Sinski, so it goes straight to the IA to help me center into the bag. And as I'm removing the viscoelastic, I'm also centering the lens and putting it in the right axis here. This one happens to be the glistening-free Invista Toric lens that tends to unfold a little bit slower, but that's okay because I'm trying to get rid of all the viscoelastic, which comes out quite easily. I use Helon, which is a very nice cohesive viscoelastic to help with the unfolding, so I can get better stability in the toricity. I'm using my chopper to help unfold it because it is a slow unfolding lens. Once I have it in place or close to in place, then I'll move on to sealing of the wounds with BSS and a cannula. And any minor adjustments can be made there. Yeah, so I like to hydrate the roof of the wound as well as the sides of the wound. I find that gives me the best seal. And same thing with the para. I try to hydrate the roof of the wound as well as either side of the wound to help get a better seal there as well. And here I'm just making very minor adjustments because as we reinflate the anterior chamber, sometimes the toric lens will rotate, and I'm just making kind of minor adjustments as I reinflate the anterior chamber and make sure that the wounds are sealed. As I make minor adjustments, I'm just trying to be happy with my wounds as well as my pressure. We can talk about a couple of principles I always talk about when I'm talking about my cataract surgery. The first principle is to maximize safety. And to maximize safety is to do things like avoid zonular dehiscence, capsular rupture, and other items like that. So key things there would be bimanual rotation and minimizing stress on the zonules, for example. The second principle is to maximize patient comfort. And when you maximize patient comfort, of course they're awake, you minimize movement and thereby improving the experience and also improving the success of your surgery if they're not fidgeting from pain. And of course, third thing is to maximize efficiency during the surgery, because the shorter your surgery, then the less likely chance you'll have any complications and better healing. Thanks so much.